Good evening, everybody. Welcome to this another session of 46th Comprehensive Course on Echocardiography, online one. May I request everybody to please mute their mics so that it will become easy for us to conduct the program. Otherwise, it creates lots of disturbance. Still, many people are talking on the phones. My request, humble request, please mute your mic. And today we have with us Dr. Nandita Chakravarti from Kolkata to talk about on measurements in routine two dimensions echocardiography. Once we have our presentation, I'll show you a live demonstration of various measurements, what we do in day-to-day life. That's what the program of today is. With these few words, let me ask Dr. Nandita to please share your slides so that we get going. I'll stop sharing and kindly share your slide, Nandita.
Right. Okay, ready, sir.
All right, please go ahead, Dr. Nandita. My humble request to everybody again and again, please mute your mic. Otherwise, you'll force me to shunt you out completely from this program. I'm requesting again and again, everybody, please mute your mic. Go ahead, Dr. Nandita. It's all yours.
Yeah, good evening. Now, we are just talking about routine measurements in echocardiography today. This is not about measurements which we make in special pathologies. When we do a normal echocardiography even, there are certain measurements that we need to take and we need to put it in our reports. So these are the measurements that we will be making mostly during our studies. After this, as Sir said, this is the theory part of it, and after this there will be a practical demonstration. So be careful and listen to this so that when the practical demonstration is made, it is reiterated and you are able to keep this in your minds when you do the echo. Now, one more recommendation I would give from my side, sir, that when you are doing an echocardiography, you should keep the normal measurements either in a file folder or pasted behind your machine, so that for a quick reference, so that you don't need to go hunting the Google or looking up some article to find out. If you have a quick reckoner, then you will be able to complete your reports faster. And also, during the study itself, that if you are getting some measurements which are not fitting, then how you should proceed to find out the cause of that chamber enlargement. Now, why do we need to measure? I mean, a lot of people could tell like this, okay, there is aortic regurgitation, grade 1, grade 2, grade 3. But why do we need to measure? Put it in your chat box. So why am I not able to see the chat box? Are you able to see? Hello? Hello?
Yeah, I'm not able to see the chat box. Anyway,
we are not able to see.
Okay, so then,
please go ahead. We'll ask the question later on.
All right, so then why do we measure? Now, measurement is something which is very precise. It is a quantitative analysis. For anything else, you are doing a qualitative analysis. That means I perceive you as something, I perceive you as fair or dark, but I haven't given you a quantitative analysis of how fair or how dark or how blue or how white something is. So a quantitative analysis will be universal, and there will be standardizations for each quantitative analysis. So you and I can't shift according to our personal preferences. Also, there will be an accuracy. When you talk about measurements, you talk about how to measure, when to measure. So there will be an accuracy in your measurements. Because there is accuracy, there will be a precision and there will be reproducibility. If you measure now, you measure 5 minutes later, the patient goes to another center and gets measurements done, they'll all be the same. There will be a reproducibility in the measurement. And it is universal. If he goes to another country, another state, it's the same thing. It doesn't differ. And you could compare. Today, if he comes with you with a measurement of X, and tomorrow, if he comes with you with a measurement of Y, you know why your measurement has become Y and has not stayed at X. So you can look for causes. Okay, what do we measure? We measure, somebody has to mute out there. We measure dimensions. So where do we measure? We measure in M mode, we measure in 2D, we measure in three-dimensional views. What do we measure? We measure linear dimensions, that is point to point. We measure areas, that is we encircle a certain area on the screen and measure that. And we measure volumes. We also do Doppler measurements. What do we measure in Dopplers? We measure velocities. Consequently, we measure gradients. We measure pressure half time, vena contractor, areas in color Doppler, and volumes also. So from here, we go ahead to our measurements. Before we start, I'd just like to put this concept of leading edge and trailing edge in your minds. Look, every echo has a dimension. It's not a dimensionless thing. So even if it's just 0.1, 0.01 millimeters, still that's a dimension. So we need to even qualify from where we are going to take the measurements. Any N-mode measurement is made from the leading edge to the leading edge of an echo. And any 2D measurements are made from the trailing edge to the trailing edge of an echo. That means if you have a line, if you look at the line and it has an anterior part and a posterior part, when you talk about a leading edge, and the anterior part is the leading edge and the posterior part is the trailing edge. So you have to use optimal, this is an universal thing, optimal gain settings, optimal machine settings, optimal pictures, textbook views are all very necessary to make your measurements true and accurate and reproducible. If you are just about putting your transducer anywhere, getting a view of any kind, you are not going to reproduce your measurements. So when to measure? Dimensions are measured in end-systole and end-diastole. Where is your end-diastole? Look for the Q wave on the ECG, and that's your end-diastolic frame. End-systole, look for the end of P wave on ECG, and that's your end-systolic frame. It's so much easier these days because the frame rate is so high, you can go really slow and then you can fix your frame in the desired point. Now, we have guidelines. We just can't go and measure anything and everything, and we can't use any view to measure everything. So these guidelines, I have just picked up there are guidelines in every self-respecting eco associations. These are the IAE guidelines. You can go on to their website or Sir can give them to you, where you should have put your which view is necessary to make an echo examination. Not only that, it comes with a recommendation that in which view you will measure the Doppler or the grayscales also. So I'm not going into this. This can easily be taken later. Let's jump into the measurements, the normal measurements that we do. This is a Plax tool and a textbook tool. Look at this. You have the aortic valve. You have everything mapped out here. So I don't need to tell you what is what. But look at the orientation of this image. Look at the clarity of this image. And look how this image is fixed in the screen. You have a little area or space below your area of interest. So that is necessary. Never take an image which goes right out of your area of vision. Remember this, that you will not get a textbook image for each and every patient that you examine, but you will have to learn to improvise and use as close to possible measurements that you are going to get from these patients. Do you think this is correct? Now, obviously it isn't. Because you see, this is an angular measurement, and no one has spoken about the angle subtending onto the posterior of the left atrium. So when you see such a measurement or a picture of, when you have such a view, don't measure. You are better off saying that you cannot take the right measurement in certain conditions. This is an M mode of aorta and LA. Look, the aorta and LA are plonk straight there. And you have we have measured the aortic root diameter and the left atrial diameter. Now you can see what I meant by saying a leading edge to a leading edge and a leading edge to leading edge. See the anterior wall of the aorta, from the leading edge to the posterior wall of the aorta, the leading edge, it is being measured. So this is a highly reproducible measurement. How many ever times you do it, this is the measurement that you are going to get in this view and in this cut. And
I'm sorry, can you show where to measure, where to where?
Ma'am, could you use the cursor to show
Yeah.
us, please?
Sure.
Anita, I'm saying the same thing.
Look this, yeah. Look at this. This is the echo. As I said, this is not a dimensionless thing. So it has a dimension. So it has a leading edge and it has a trailing edge. So you have put your cursor at the leading edge. Sorry. At the leading edge. And then you have taken the measurement up to the leading edge here. Okay. This also has a leading edge and a trailing edge. So this is the leading edge and this is the trailing edge. So you have a measurement here. And look here also. You have taken, this is the LA, and you at the highest point where the LA is most distended, you have dropped the cursor on the leading edge of the posterior wall of the aorta, and floor of LA, the posterior wall of LA, you have dropped the second cursor onto the leading edge. So that is how you are supposed to be measuring. Am I clear on this, or should I repeat myself, sir?
Repeat it, ma'am.
Okay.
Ma'am, could you correlate the above picture with the M mode so
all
that
right.
we can understand?
Okay. This is the aorta, right? And this is the left atrium. This view you would have, I'm going back to the Plaque's view then. Okay. Look at this Plaque's view. Correct. So this is the aorta. This is the aortic valve. Any doubts there?
No, ma'am.
Okay. Here is the left atrium. This is the aorta. This is the left atrium. Here you have the mitral, the left ventricular inflow or the mitral valve. And then here you have the outflow or the left ventricular outflow tract and then the aortic valve. So the cursor, when it comes to, it drops through the aortic valve and into the left atrium. But when you do that, look at this view. You have shifted it so that it's more or less perpendicular. Got that? So you have cut through the aorta and the left atrium in a perpendicular. And here you have the measurement as I have explained to you. Now have you correlated? This is the aorta, this is the RVOT, this is part of LV. You can see the mitral valve, tip of the mitral leaflets here. And here is the M mode. See, look at this. This is the aortic valve, the way it is closing. This is the aortic line closure, and this is the opening. You can see the two cusps of the aortic valve, the RCC and the NCC. Is that better?
Yes, ma'am.
Ma'am, can you please show us the leading edge and the trailing edge on the top?
Look, anything, even if you draw a line on a paper, okay, there will be a dimension of that. Understood? Correct. You can't have a dimensionless thing. You will have, look at this line. There is
Can you put the cursor on the top image? Where is it on the top image? Yes, on the top.
You're
Yes,
not
this
going
one.
to look at it. You're not going to look at it in the top image because this is M mode measurement you are doing. Correct. So you are going to, you have taken the M mode here. Now you have this. This is the anterior aortic wall, and this is the posterior aortic wall. Now you have put your cursor at the leading edge. That is, see, there is a dimension. No, there is what, however minuscule it is, there is a dimension of this line.
Right.
Get that?
Yep.
So whatever is coming here is the leading edge. This is leading, and this is.
Is that the top line or the bottom
Yes,
line?
that's a top line. The top line is leading. And
Okay, got it.
the toppers
Madam,
are leading, no?
Madam, are there supposed to be two lines there?
Yes, they are edge, the edge, not two lines. Look, anything you talk about anything, you just draw a line on a paper.
One part of the edge is a leading edge and another part of the edge is trailing edge. Is it correct, madam?
Trailing edge. Yes, that's it is. That's what it is. So this is the leading edge. Yeah, the one that is leading. And the one that is trailing is the trailing edge. So you take it from the leading edge to the trailing edge, and here also to the leading edge of the second posterior.
Posterior.
Yeah. And here also,
Madam,
Hmm?
madam, each part, like if it is an artery, lateral wall and medial wall, and lateral wall will be having leading edge and trailing edge, and medial walls also will be having leading edge and trailing edge. Is it correct? Is it
every
right,
line
madam?
every line will have a
Yes, yes. Thank you,
head
madam.
to edges. Okay, because it's a
Okay,
dimension.
okay.
So
Yes.
here also you will have a leading edge to a leading edge measurement. That's in M mode. But were you measuring it in 2D? We will show it to you. Okay, let's go through the M modes first. Now, here is the M mode of at mitral valve. Feel free to interrupt if you feel that anything is not very clear, but make it short. So we have, here is the, now there's a lot of controversy. Should we have an M mode? Should we not have an M mode? But look at the temporal resolution. The mitral valve, it's opening and closing 72 times per minute. And you have each and every dot on it clearly denoted. So here you have the DE excursion, okay, EF slope, the A wave, and the closure line, the C closure line. Okay, this you would have already done in your views. So I'm not going in much into this, but these are the points. This is how you see them. The main measurement that we require in this is the E point septal separation. That is, the E point is the peak of the mitral valve, mitral leaflet opening from E point, from E point up to the septal edge, you measure it, and that's the EPSS. And that gives you a very good idea of the function of the left ventricle or dilatation of the left ventricle and how much the mitral valve is opening. Filling pressures you will be able to gauge from that, though it's a qualitative measurement. This is the most important measurement in the M mode measurements. And this is the left ventricle. What are we trying to measure here? We are trying to measure the intraventricular septum, the left ventricular end diastolic volume, end diastolic linear measurement, the posterior wall, and the left ventricular end systolic diameter. Got it? Okay. So what are we getting? What is the outcome of measuring this? Now, I'm not going again into the leading edge and trailing edge. You can make out here how they have measured. See, here is the IVS. Here is the LV diameter in diastole, in LVPW, and the LV diameter in systole. Out of all these outcomes that the machine has given you, the only important outcome here is the fractional shortening. Nothing else you need to look at, because the EF measurements in TCOLS is no longer acceptable. It makes assumptions that are wrong. And the volumes are also not calculated from these people. Now, why is this such an important measurement? Because of this measurement which comes out of these measurements. All your machines have this formula fed into it. So don't break your heads trying to remember what it is. Just the concept, for the conceptualization, I have given this formula that we calculate the LV mass from the intraventricular septum and the posterior wall. The left ventricular mass is very important in the main lifestyle disease that is occurring in our country and elsewhere, that is hypertension. To denote what type of left ventricular hypertrophy it is, we have taken into account another measurement called the relative wall thickness. And the relative wall thickness is IVS plus PW, or better still, 2 into the posterior wall divided by the left ventricular internal diameter at diastole. And this is the normal value. We won't go into normal values. I'm not muddling this up by normal values because that comes in your textbooks and so many articles. Now, types of LVH. Spend a minute on this. This is a normal left ventricle. Normal left ventricle. The posterior wall thickness is normal. The left ventricular mass is normal. So you have a normal left ventricle. This is an left ventricle which talks about eccentric hypertrophy. The mass has increased, but the relative wall thickness has not increased. This is the kind of left ventricular LVH that you have in volume overloads. That is kind of, and volume and pressure overloads like aortic regurgitation, mitral regurgitation. The left ventricular volume also increase in addition to mass. The most khatarnak one that we kept talking about is concentric hypertrophy. Before that, one word about concentric remodeling. This happens when there's an adaptive change to something, an increased afterload, like say, for example, left ventricle, hypertension or aortic stenosis. So you have a mass, the left ventricle relative wall thickness is increased, but the mass is not. And therefore the cavity is compromised. See here, this is concentric hypertrophy, in which you have both increments in the left ventricular mass and the relative wall thickness. And this is an important predictor of morbidity and mortality in cases of hypertension. So this is a very important thing, that how you do your reporting, how you measure these two parameters, and ultimately you incorporate into your report is a very important thing for these patients coming to you for hypertension, with hypertension. And mind you, they're not.
Excuse me, madam.
Yeah, sure.
Can you tell us the difference between concentric remodeling and concentric hypertrophy one more time, please?
Yeah, here the relative wall thickness increases. That means that the cavity is being compromised, but the mass does not increase as a whole. There is an adaptive change to this thing. Here the mass also, look at this. This has gone outward, isn't it? Here the cavity is also gone. You're dealing with a smaller cavity. And the left concentric hypertrophy, there is a lot of hypertrophy also. The LV mass is also increased. So both you are compromised with the cavity, the relative wall thickness has increased, and the mass also has increased simultaneously. Concentric remodeling also has a very bad prognosis ultimately, because it will lead to LV dysfunction and heart failure. But the most patients will come to you with this kind of left ventricular hypertrophy. Anyway, so that is just to put in context the necessity of measuring these parameters carefully. Now, this is the cardiac planes, which you have already done. So I'm not spending time with it. Just remember the short axis, the long axis, and the apical planes. Are you okay with that?
Yep.
Okay. So let's proceed. Now, this again, just putting into context and recollecting from your previous lectures, how the plaques view looks like. This is the cut you are taking through the plaques. You've got the aorta, the LA, the inflow, the outflow, a bit of RV here, and a lot of left ventricle. So some similar images, okay, where you have the, this is the one of the short axis at the great artery level. You have the aorta here, you have the pulmonary valve. This is RV inflow and outflow seen together. This is part of right atrium, part of left atrium. And the intra-atrial septum is very well seen in this particular view. Another short axis at the level of the papillary muscles. See, you have got the papillary muscles here, and a cut is showing the papillary muscle, the medial and the lateral papillary muscles with a bit of RV and LV and the interventricular septum and the walls. We'll go to it again when we come to the coronary artery supply. Here is the apical view. It's RV, LV, RA, LA, and your transducer will be at the apex, and all four chambers will be delineated. Two chamber view at perpendicular to the apical view, and last but not the least, you go to the subcostal view where you see the subcostal four chamber, you see the subcostal short axis, and you also look at the IVC. Now, starting the volume measurements or chamber quantification. Left side. So these are the frames that you need. You need an apical 4 chamber, end diastole, apical 4 chamber, end systole, apical 2 chamber, end diastole, apical 4 chamber, end systole. Okay. So you will freeze as per recommendation. Mostly all of the machines will ask you to do a modified Simpson's calculation. Nothing great. You will go to one of the annuli. It will be demonstrated to you very clearly. Now this area is delineated first, and then the length from the top part of the apex drop down to the line which connects the annulus. Clear?
Yep.
Okay. Others, I can hear only one voice. Anyway.
Yes, ma'am.
Same way, the left ventricular end systole is also measured. Okay. Be careful of the apical 2 chamber. It is very apical 2 chamber really needs a little expertise to get to, at least I feel that way. So make sure that you have a good apical 2 chamber also. Otherwise, your measurements will go for a 6. 2 words of caution. 1, make sure your endocardium is seen. Go and make sure your apex is not foreshortened. For that, go right out. Yeah. Hello. Yeah. Go right out, and where you start losing the image, then come back and clearly delineate the apex. So that will give you the correct apex and not a foreshortened one. You get a foreshortened one, again your volumes are not correct. Moving on, coming to the left atrium. The left atrium, there's only one measurement, one volume measurement. We will choose the frame that is just before the opening of the mitral valve. And then at that point of time, the left ventricle is fully distended. Here again, you need a good apical 4 chamber and you need a good apical 2 chamber. Now, you can make out how the area has been missing. Come right down from the annulus, cover the entire left atrium. Remember to leave the pulmonary veins out and then go and close the circle. Similarly, in apical 2 chamber, take the length in both, the maximum length in both apical 4 chamber and apical 2 chamber. The machine will automatically select the minimum, the lesser of the 2, and give you the left atrial volume. Right ventricular measurement. We would prefer to do it in an RV focused view. You have already done an RV focused view? Hello?
Yes, ma'am.
Okay. So you know how to get an RV focused view. Get an RV focused view. Again, look at it in systole and diastole. Freeze both frames and measure 3 diameters and the area. I am sorry, I have not, I think I omitted to show you the area here, but okay, so we'll demonstrate. So what are the 3 measurements that you need? One is at the annular level, one is mid right ventricle, and other is the maximum length. So what will you get? You will get a volume analysis, systole and diastole and systole. You will get a fractional area change, and you will get a RV ejection fraction. Here, the fractional area change is probably the most important thing regarding the contractility of the right ventricle. Right atrial volumes. This is done in the RV focused view, and this is done in the apical 4 chamber view. You can do it only in the apical 4 chamber view. It would not make much of a difference, but you would measure the area, you'd measure the mid right ventricle and the maximum length, and you will get the right atrial volume. Before we leave chamber quantification, one thing is to be said. Look, we would like to go in for index measures because in India, we have 60 people, tall people, and we have puny little ladies who are measuring, who are not even 5 feet tall. So always, whenever you are reporting, index your measurement to the body surface area, feed it into the machine directly, and every time you report you might mention the normal volumes, but also index it to the body surface area. Okay, coming down to the great arteries. As far as the aorta is concerned, we usually measure at the annulus, at the mid-sinus level, and sinotubular junction. So got it? You would open the
Hello,
aortic
ma'am.
valve
Can you
out.
explain
Yeah.
major axis and minor axis, please, again?
I think you just let it
Dr.
go.
Shivaji, wait for some time. We'll come back to again. Please do not disturb in between. Just write our point and raise your hand when the question answer session comes up. Dr. Nidya, go ahead, please.
Okay.
Madam, ABC again, please.
Yeah. See, this is the level of, you will open out, scroll the aortic frame till it is in somewhere in mid-systole. Okay. Then look at the annulus, the attachment of the aortic valve to the aortic root. Okay, here, this point. Remember, we were talking about trailing edge, trailing edge to leading edge. So here you put one cursor here, and the other cursor here, and that's your aortic valve annulus, right? The next one is at the level of the sinuses, the maximum diameter. Same method. And the third one is the sinotubular junction. That is where the ascending aorta meets the sinuses. Done? Okay. Now going to further measurements in the ascending aorta arch and the descending thoracic aorta. So I'm not spending much time on this because these are measurements that you will be doing only when there will be a pathology, and it will be dealt with the pathology which is there, like maybe coarctation of aorta or say dilatation of the arch. But just note that the measurements made is before the takeoff of the innominate artery and after the takeoff of the left subclavian artery. These two are the measurements, and one in the midpoint of the descending thoracic aorta. I love this thing. This is a lot of slides are pirated from Sir, but this is the best one I could pirate. So this one is the fish mouth, and the mitral valve looks just like this when it's like it's opening and closing, like a mouth of a fish. Mitral valve area is taken in the parasternal short axis view. Okay, as you cut across the mitral valve orifice, you will open it at the maximum area. Don't look at any ECG or anything, because if you're dealing with a mitral stenosis, and that's when you will measure the orifice, the maximum area is the area of the mitral valve. And start off at any point on the orifice and trace carefully the entire area that is enclosed by the mitral valve. Okay, correlated with Doppler measurements. MAPSE. This I think Sir will talk more about, but I'm just telling you how to measure it. The cursor comes right through the lateral annulus of the left ventricle. And the mitral annulus, this is the mitral annular plane, systolic excursion is measured. How do you measure? This is the nadir. The lowest point, you put a cursor on that and go to the highest point, the peak of this mitral annular plane excursion, and measure. And this is your MAPSE. This, the distance from here to here is your MAPSE. It's a linear measurement. Similarly, we are going to the...
Excuse me, ma'am, didn't get it.
Okay. This is the lateral annulus. Now, during the cardiac cycle, the annuli make a lot of movement. Do they or do they not? So this movement is a reflection of the left ventricular contractile function. So it's a very easy measurement to make. That's why we make it where we are not able to do strain or any other measurement. We put the cursor through the lateral annulus and then record it in M mode throughout a few cardiac cycles. After the recording, you freeze, take a point at the lowest point of the nadir of this particular mitral valve annular plane. Put a cursor over there, and then take the next cursor at the peak of this mitral annular plane excursion. The distance between the two, that is how much the annulus has moved during that particular cardiac cycle, will give you mitral annular plane systolic excursion. And this will reflect the left ventricular systolic function.
Excuse me, madam.
Yes.
Thank you, ma'am.
Does this show you how much the lateral or the mitral annulus opens every time?
Mitral annulus merely moves, no? It is not a valve. Like it just
Right, but this measurement, what's the significance of this
as
measurement?
I said, no, it will tell you about the left ventricular contractility. Because you see the left ventricle, when the left ventricle contracts, no, the annulus is lifted. The apex goes tortuous, but the annulus is lifted upwards. So this
Got it, yes.
this is an indication how much, or this is a function of the left ventricular contractile function. Okay.
Got it. Yeah.
Similarly, we go to the tricuspid annular systolic excursion. Here, your cursor was going through the lateral annulus of the left ventricle. Here, we put the cursor through the tricuspid valve, the free tricuspid valve annulus. And over here, the same way we measure. See, we've taken the lowest point here and the highest point here. And the distance between the two will give you the TAPSE. Here again, it's a measurement of the right ventricular function. And it's a very good indicator and a very sensitive indicator as to when the right ventricular function is starting to deteriorate or the right ventricle is failing. Okay.
Madam, the nadir of this for the TAPSE is much different from the MAPSE, isn't it?
No, it isn't. See, here here it is, the nadir is this, right? The lowest point. See, they have measured it here in this particular picture. Can you make it out? It's the same point at this.
But they have drawn the arrow straight down, madam, here in TAPSE.
Yeah, they have. This is a linear measurement. We are not talking about the slope. If we were talking about the slope, it would make a difference. I placed it here or there or somewhere the same. We are not talking about the slope. We are only talking about the distance this particular point has covered. So it will remain the same wherever I put it. You know, this is the distance from here to there. That is the distance. There is a slope because this is a temporal breakdown. Over time, you're seeing it over time, but I have nothing to do with the slope. I'm only measuring the distance covered. Okay.
Ma'am, same thing is with MAPSE.
Same thing is with MAPSE.
Okay,
You're
thank you,
measuring the distance covered.
We can also take as a perpendicular drop down there also, madam.
Drop down, yes. That is exactly what has been done here. It's a perpendicular drop down. So
It has been only done for the TAPSE, madam, but not for the MAPSE. So
no,
it is
it's
okay
also
for both.
for the MAPSE. It's okay for both. We are only talking about the distance traversed. We are not
Thank you.
interested in the slope or the time taken. Okay.
Thank you. Okay. Thank you.
But we only do this because we do this in M mode because in a 2D it's a much more difficult situation. It's not, you will not get the frames. So you're not going to get the distance either that way. You have to put a temporal resolution on this, right? Okay, right ventricular anterior wall can be measured also in the Plaques cube, but we prefer it to be in subpursul because in subpursul you get a much better resolution and you zoom in onto the right ventricular free wall in the end diastole and make a bigger area of interest and measure, okay, from the edge to edge. Right ventricular outflow tract. Now, these are not mandatory measurements that you make, but we are just for completion's sake, I've put it here, that you measure the proximal RVOT, you measure the pulmonary annulus, okay? The midpoint is the distal RVOT. And this will become important when you have a pathology which results in RVOT dilatation or RVOT, rotation or something like that. In those type of pathology, like for example, tetralogy of Fallot and all, these will become an important dimension. Talking about the inferior vena cava. You go to the subcostal and focus on the inferior vena cava. And why is this such an important measurement? Anybody?
Volume
Hydration status.
Yeah, those of you who have been working in intensive units and have been faced with volume challenges, for you, this is a very, very important measurement, because IVC will tell you what is the volume status of the patient. Not only that, when we want to go and RA pressure also will be depicted in the diameter of the IVC. And we look at the collapsibility index. That is, we take an M mode through the IVC at this point, and we measure the maximum separation and the minimum separation. So that gives us the collapsibility index. Going over to Doppler. So we have pulse wave Dopplers and continuous wave Dopplers. Color Doppler is also a pulse wave Doppler, so is tissue Doppler. Driving?
Madam, could you repeat, please?
These are the Doppler measurements that we are going to talk about. Okay. Now, you have already been taught about continuous wave Dopplers, correct?
Yes, ma'am.
We have too much noise, Mr. Ojha. Mute your mic. Yeah.
Dr. Ojha, please mute your mic. Otherwise, I have no option but to shunt you out.
Okay, thank you so much. Now, continuous wave Doppler employs, you know that there's one crystal which is receiving and one crystal which is remitting the Doppler waves. So I'm not going into this really, but just remember that wherever you have a very high velocity flow, you cannot do anything with your pulse wave Doppler over there. So continuous wave Dopplers will have to be used. All the other Dopplers are pulse wave Doppler, be it color flow Doppler, tissue Doppler, or the normal pulse waves. Now here we have, okay, that again is technology about pulse waves, so we are not going into that. Now, for all normal valvular measurements, we will use our pulse wave Dopplers. Mitral valve, aortic valve, pulmonic valve, tricuspid valve, IVC flow, all these are very low flow situations. So we use our pulse wave Doppler. But whenever you come up with a pathology like mitral stenosis, then you have no option but to go for a continuous wave Doppler. So here is a envelope showing the flow in a mitral stenotic, in a mitral stenosis patient. The trick here is do nothing but simply trace the envelope. Put your cursor at rock bottom of this envelope. Go very carefully up. Go ahead and trace the entire envelope and end it. The rest your machine will do. What will it do? It will show you the maximum velocity, the mean velocity, the maximum PG, the mean PG, the velocity time integral or the VTI, and it will give you the mitral P half time and the area by P half time. So one go, you have your entire measurement organized. So just, you do not have to break your heads. But in case you are not comfortable and you want to re-measure something, remember the P half T, draw a small cursor here and drop it down across the slope. That gives you the pressure which it achieves at half the time that it takes to come down to zero. And that from that you will derive the area.
Ma'am, can you repeat this, ma'am? PST, ma'am.
I think I won't, because I think it's a far easier thing to do. You know, there were times when we would not get good envelopes or good this thing, but I think it's best for you to simply trace the envelope and go ahead like this. See, nothing there. What it has done is it has taken the peak of this, okay, then gone down to where the pressure has come to the lowest before the atrial kick, if you have the atrial kick at all. So these 2 points, if you just plot, you will get your P half time and your area by P half time. Got it?
It is the pressure at the half of the diastole. Isn't it, ma'am?
Pressure at the half, yes.
No, it's
half
the
time does
drop of pressure to half of it
Half.
over a period of time. Pressure half time is drop of a pressure to half of it over a period of time. That is pressure half time.
Done?
Go ahead. Go ahead.
Which means if your pressure is say X, then the time at which your pressure becomes X by 2 will be pressure half time.
Okay, ma'am. Thank you, ma'am.
Okay. It's just like that radiation thing where they, you know, the time it takes for the radiation to become half, the same way. Anyway.
One more question, madam.
Mhm.
So now for this one, you're using a continuous wave Doppler. Is it the same if you're using a pulse wave Doppler?
Yeah,
You
it is,
measure
the,
the same way?
it is the same if you're using the pulse wave Doppler. Yeah,
Thank you.
definitely. But this will not be an envelope, no, when you are using a
Right.
pulse wave Doppler. This is
Right.
definitely a stenotic valve.
Right. Okay. Thank you.
Coming to the aortic valve. By the way, whatever you can do for the mitral valve, you can also do for the tricuspid valve because it's a similar kind of situation. But rarely do you get a tricuspid stenosis. Now, here is the aortic valve envelope. And similarly, also the pulmonary valve envelope will be also the same, and you can make the same measurement. Here too, the simplest way is just to trace the envelope. Get a good envelope, freeze, select the best one you can, and measure it. Do this about 2 to 3 times, and the average will give you a very good measurement. So what have you got here? You've got the Vmax. Derived from it, you've got the maximum pressure gradient. You've got the mean. Tracing out this, you've got the mean velocity, and you've got the mean PG. Your VTI has come, right? And the aortic valve area also has come. Okay.
Ma'am,
Because one second. No, forget that. Aortic VTI. We'll stop it there. Now ask your question.
ma'am, to trace the aortic valve curve, we have to select VTI function in the machine.
Pardon me?
Ma'am, to trace the aortic valve area to aortic valve curve here, we'll
Huh.
have to select the VTI option in the machine.
What option?
VTI option.
VTI.
No, you just simply go to the aortic valve. This entire thing will come all together. You don't have to select any option in there.
What is VTI? VTI is a distance at which the blood travels with every beat. So once you travel the peak and mean, just trace the envelope, it will give you VTI automatically.
Okay, sir.
This is the summation. VTI is a summation. So since you are tracing the envelope, you've already got every blood vessel, blood corpuscle traveling the velocities. So it's just summed up. That's all. You don't have to go separately to anything.
Okay, ma'am.
Okay, this is just another one. Now, this is a very important measurement and a mandatory measurement I feel in every echo, be it a normal echo or an abnormal echo. This is the measurement of the stroke volume. This particular formula again is fed into your machines. So you don't have to worry about that. You have to worry how you have measured it. you have to take the LVOT measurement. LVOT measurement just 0.5 to 1 millimeter away from the annulus of the aortic valve. This is the left ventricular outflow tract. And why this is chosen? Because this is the place where the most laminar flow comes. So this is the LVOT you will have to take again from trailing edge to leading edge, this measurement. And you will have to put your PW into the left ventricular outflow tract, the same place where you took the measurement, and get your LVOT flow. After you get your LVOT flow, you will have to measure, just like I said, trace the envelope right from this point along the borders and then terminate it here. Once these two measurements are made, the machine will automatically calculate your stroke volume. It will derive the radius and then it will go into the LVOT BTL and the stroke volume will be given. You can calculate the cardiac output. It will even calculate the cardiac output if you have ECG gated your study. Done?
Just a short question. Do we need to take averages of 2 or 3 or just one?
Everything. If you are having, if you want to give a very good report, if you are having a normal patient, a normal heart rate, you would do very well to take an average of 2 to 3 beats. When, if it's a arrhythmia patient, especially if it's an atrial fibrillation, that would go up to 5 beats. But however, most people don't have the time. So I would suggest that you get a very exemplary view, a real textbook view and a real textbook measurement and steady hands. So that should give you, I'm not recommending this, okay? This is off the record. You are ideally supposed to take more than 1 beat.
Thank you.
This is Sir's favorite. Myocardial Performance Index. And you don't need a very hi-fi machine. All machines have simple PW Doppler. So you will be able to measure this. And Myocardial Performance Index is a very good measurement of the entire myocardial performance because it measures the end. It is measuring diastolic function as well as systolic function. So how do we measure it? Look, these are the 2 views that you need to take. One is at the level of the tip of the mitral valve with the mitral valve flow pattern, and another in the aorta with the aortic valve flow, the aortic valve flow. Okay, these both are normal patients. Like, so you use your PW Doppler for this.
Is this a Plax view, madam?
Sorry?
Is this a Plax view? What view are we taking this measurement?
No. Neither of them are Plax view. This is coming from an apical 5 chamber, and this is 5 chamber, this one, and this is coming from an apical 4 chamber. In a Plax view, where will you get this? You are not perpendicular to the thing. You're parallel.
Right. Yeah.
So you will not get these flows at all. So these are the 2 flows that you need to get. What do you need to measure? Measure the closure to opening. This time, okay, where the mitral valve closes and again the mitral valve opens. Measure this and measure the ejection time. That is the opening of the aortic valve to the opening of the, to the closing of the aortic valve. What are you going to do with these parameters? What have you measured? You have measured mitral valve closure to mitral valve opening. What is included in this? The isovolumetric contraction time, the isovolumetric relaxation time, and the ejection time. So these 3 are summed up. You subtract the ejection time from here and divide it by the ejection time. Spend a little time on this because this is going to hold you in good state later on when you are trying to assess or figure out what left ventricles are doing. What is it about? You see, if a normal ventricle, you will have a normal contraction time that is fast and quick, a good ejection time. This will be long and this will again be short. As the left ventricle deteriorates, both these times will get, this time will be getting compromised in relation to this time and this time. It will take more time to contract and it will take more time to relax. Come to the pressure points where they can contract and relax. You get it? Yeah? Hello?
Yes, ma'am.
One more time, please.
Once again, ma'am.
Ma'am, please once again.
See,
Once again.
you have, from when the mitral valve closes, what happens? The left ventricle starts contracting, then ejects, and then it relaxes so that again the mitral valve opens. That is it, the cardiac cycle.
Mhm.
That's it. There's nothing not to understand about that. Now, as the function ejection, what are you ultimately trying to achieve? You're trying to achieve the stroke volume, correct? So when the ejection time is good, then it's a good functioning ventricle. But as the ventricle deteriorates, what increases? These times increase. And this time will be getting compromised. Like your ejection time is shorter and your time to reach the pressures for the aortic valve to open and for the aortic valve to close are becoming closer and closer, correct? The ejection time is shortening.
But why are there two lines in ICT and IRT, madam? There should have been one.
Why? This is a time. This is a time interval. Isovolumetric contraction time. Why should not there be two lines? How are you going to measure time if there isn't a separation?
Okay, I got it.
And this is also a time, isn't it? This is also a time. This will get compromised. Whereas these two will become lengthened.
Means ET will become squeezed.
Yes, absolutely. Because this ventricle is taking more time to this thing and then it cannot sustain. Because the afterload is more. So this ventricular performance is deteriorating. So stroke volume is going down. So myocardial performance index will become a function of the time of ICT and IRT divided by the ET. The longer it takes to reach these levels, the more the myocardial performance index. So you have a myocardial performance index which is going higher and higher. So the lower it is, the better it is. Similarly, you can use the TDI. For that, you have to take two views for this. You'll have to take a view of the mitral valve inflow, outflow, and you have to take a view of the aortic valve outflow. For here, when you use TDI, you simply put your tissue Doppler on the annulus and they get this particular scrolling. And from the same view, you can measure both. Done?
Yes.
Ma'am, please tell this again. No?
When we are measuring with the Doppler, then I have to put my cursor on mitral valve tip and get the mitral valve flow. And then I have to come to apical 5 chamber and get the aortic valve flow, isn't it?
Yeah.
Right? I can't get it in the same view, can I?
Yes, ma'am.
I need to use two different views to get these two pictures.
That.
If I'm using tissue Doppler for that, I don't need to go to any view. I can just take it in one view. I can just put my cursor on the, Sir will demonstrate this because it's one of his favorites.
Tissue Doppler at mitral valve annulus, ma'am.
Annulus, yeah. He will demonstrate and that time I think the better clarity will come with this.
Okay.
Where do we put the pulse wave in the tissue Doppler? Where at
Annulus,
what point?
annulus. This is annular
Annulus.
movement. Sorry. This is annular movement. This is annular measurements.
Middle arm.
Yeah. This is the
We'll come back to it again later on.
Yeah.
Hold on for this moment because we have not talked about tissue Doppler. And let's talk about proper
I'm sorry.
Doppler. Yeah.
right. So okay. So I'm just skipping this. The same way you can do it for the right ventricular, the right side, where you can either use the tissue Doppler or two different views to get the RVOT flow and the pulmonic valve flow and the tricuspid valve flow. Okay. Here the mitral, the inflow, outflow aortic, there the inflow is tricuspid, outflow pulmonic. Done? Sir will measure, Sir will demonstrate. I think whatever confusion you have now, you will get rid of that by the end of this session. So I just put this RV inflow view because you should be using this in order to look at various structures and the tricuspid valve regurgitation, to which we are going now. This is the envelope of tricuspid valve regurgitation. See, look, it is pansystolic, it is blunted, and it is measured by putting your cursor through the tricuspid valve. The best way to do it would be to use an off-axis view, that is, lift the right ventricle and the RA a little to anterior, and you can get this entire jet, or you can get it from the RV inflow view. So what can you do here? You can measure the peak, or you can trace the envelope and get both the peak and mean. What is the use of this measurement? To get the right ventricular pressure. You add the right atrial pressure and you will get the pulmonary artery pressure here. Okay. Now, one more view for the AV valve regurgitation. This is the tricuspid valve and this is the mitral valve. I'm not going into the details of what more you can do here. Those are a little advanced. Coming to aortic regurgitation. You will have to get a good apical 5 chamber and place your cursor right there in the continuous wave. Remember, the aortic regurgitation jets are high flow jets. So you're not going to act here with pulse wave. The continuous wave is necessary. Get a good envelope, and the only measurement you need to take here is pressure half time. Because the pressure half time here tells you the grade of aortic regurgitation. Okay. Pressure half time, again, just as you had measured in the mitral valve, the same way, put a cursor at the beginning of your envelope and at the end of your envelope. And the machine automatically calculates the pressure half time. And here we are not looking at any orifice or anything. It's just the pressure half time that is important. Similarly, this can be done in the case of pulmonic valve. Okay, coming to diastolic function. So, sir, is this been covered? Hello?
Not yet. Diastolic function has not been covered. We'll talk about it later on.
Okay. So I'll just tell you, if you measure diastolic function, put your cursor at the tip of the mitral valve and use a pulse wave Doppler. Okay. The TDI, we haven't been taught, fine, that's okay. But remember that in the diastolic function, the TDI is plays a very important role. Should I skip this, sir? Pulmonary venous flow? Or, hello? Sir, are you there?
I'm there. Please go ahead.
Okay. The pulmonary venous flow is when you put a pulse wave Doppler into the vein of whichever vein is properly visible to you. It's usually the right-sided ones because they come in the line of your interrogation. So what are the waves that you see? You see in the normal flow, you see a first an S wave, then with systolic wave, you'll see a diastolic wave, and then you will see the flow reversal. And these are the three waves. For assessment of diastolic function, you will need to measure the duration and the length of these waves. How and where, that will be taught to you when you are doing your diastolic function. But here it is suffice to say that you carefully map this and learn how to measure it when you are doing your hands-on. Again, I will not go through this velocity of propagation. Coming the next, the color Doppler measurements that we usually do, the most important one is the vena contractor. In the vena contractor, you are looking at a regurgitation jet. And this vena contractor gives you an idea of what is the grade of the regurgitation. So you measure, you freeze the frame where you have a good regurgitant jet. And then you cover the entire regurgitant jet from one side to another. And this will be your measurement. It's a linear measurement expressed in millimeters. And this will be the measurement of the vena contractor. You will come across this measurement will be done again and again when you are dealing with regurgitant lesions in the different valves. And at that point of time, your expertise with this will increase. Now, sometimes we measure the area of the jet, especially when the jet is a central jet and the jet covers the entire, is well covered in the left atrium. So in that case, we fix the maximal jet in the frame that is seen, and then we measure it from one point of the jet, covered the entire jet area and express it as a fraction of left atrium. So the LA area is, suppose it's this and the jet area is this, then how much of the jet area covers the LA area will tell you what is the regurgitation rate. Yeah, calculate the LA area is traced, the MR area is traced, and the ratio is expressed. It's expressed as a ratio. So measurements are over, not over, but for now we would take leave of measurements. So do we take a QA now or later?
Just show the arterial territory of the wall motions, and then
quickly going through the coronary artery territories. This is a 4-chamber view, you can see, and here is the coronary artery territory delineated. So what you see here is the 4-chamber view. If you talk about the right ventricle, it's mostly supplied by the right coronary artery. And this area, that is the inferior septum, this is the part of the inferior septum, is supplied by the right coronary artery too. And then as you go into this is the lateral wall, and the lateral wall is supplied either by the LAD or the circumflex artery. And this is the apical part of the interventricular septum, is also supplied by LAD. When you come to a 2-chamber view, you can see, just a minute. You see the anterior wall that is supplied mostly by LAD, and also a part of the apex is also supplied by LAD. The inferior wall is supplied by the right coronary artery. Now taking the same in the long axis also, you can see this part of the septum that's supplied by LAD, and you can see this area is, so 2 minutes, is supplied either by RCA or the circumflex artery. If you take we take the 17 segment model of the left ventricle, and in the 17 segment model, this is the coronary artery distribution is delineated.
Take a break for some seconds. You're coughing a lot.
It's okay. We'll just, this is the last part of the presentation, but I just will finish. Choked over. So look at this. In the basal, if you take it, I find it easiest to take it in the parasternal short axis view, where we can see all the 17 segments in serial cuts. So in the first short axis view, where the mitral valve or the LVOT can be seen, we divide the the ventricle into 6 segments. That is, the first here, this is a part of the interventricular septum, and this is the anterior part. This is the part of the interventricular septum, which is the inferior part. And this is, in the basal wall, you can call it inferior, infralateral, lateral, and anterior. Is that clear?
Yes, ma'am.
Okay. Now,
Dr. Nandita will stick to 16 segment model because most of the machines they still have 16 segment model depiction.
Right, sir. Okay. Oh, this is this has 6 segments. Similarly, you have a repetition of the segments in the mid level, where you have again 6 segments. You have 2 segments in the interventricular septum, the anterior lateral, infralateral, and the inferior wall. Okay. Once you go to the apex, these segments are reduced to 4 segments. That means you have 1 interventricular septum, 1 anterior, 1 lateral, and 1 inferior. That's fine. So now each of these territories, what is the supply? Here you have, look at this thing. Here again, you have the apical fourth chamber. And the apical fourth chamber, the ventricular supply is usually again from correlating with this picture. It's from LAD at the apical cut and the RCA, and probably the RCA or LAD in the mid ventricular septum, right? Okay, and here is the lateral wall. As we explained earlier, the lateral wall is supplied by the LAD or LAD or the circumflex. Fine. Coming to the 2-chamber view. Here is the 2-chamber view in which you have the anterior wall and you have the inferior wall. Look at it. Here again, you can see the supply. This is the RCA supply and this is the LAD supply. So the anterior wall and the apical cap, they have apical segments, they are supplied by the LAD, whereas the other walls are supplied by the RCA. So that about sums up this thing. The last but not the least, we go to the RV supply territory. This is in the RV, RV 2-chamber view, where you have the anterior wall of the right ventricle that is supplied by RCA, and the inferior wall is supplied by the posterior descending artery usually. So here also you can see that when you are taking an apical fourth chamber, the lateral wall of the RV is supplied by the acute marginal branch. And this again is LAD, and a little bit of supply from here from RCA also. So that about sums up the coronary artery supply. Echo can image the coronary arteries also. So look at this. This is a beautiful image where they have looked at the left main coronary and the LAD going right up there. So similarly, you can use the RCA also. And these images are very useful in detecting certain diseases which involve the coronary artery, especially the coronary. Okay, so I'm ending my talk here. So we'll take over for the practical demonstration and addition or alteration of whatever we have spoken just now. Over to you, sir.
Which view, ma'am? This one.
You know what we do generally? We just go to a parasternal short axis view, seeing the aorta and the right ventricular outflow tract. Then we tilt it. We tilt it so that the coronary arteries open out. So this is a thing.
Correct.
Whoever is
Last time Gupta sir told, yes, I had.
Whoever is beginning beginning, it's a difficult view to achieve, but the day you achieve this, you'll really feel good. You feel you've done something great. So should I stop sharing?
I think let's hold on this present moment.
Okay, sir.
And we'll take up question one by one.
Yeah.